Next, I would like to welcome Dr. Edwin Zishiri from Allina Health, Minneapolis Heart Institute. Dr. Zishiri will be discussing aortic root and arrhythmias, a brief update on the cardiac conduction system in health and disease. Dr. Zishiri, a cardiac electrophysiologist at the Minneapolis Heart Institute. After receiving his medical degree from the University of Zimbabwe in Harare, Dr. Zishiri completed his cardiac electrophysiology training as Chief Fellow and Cardiology Fellowship at the Cleveland Clinic, and completed his training at Boston University as Chief Medical Resident. He went on to hold a number of physician leader roles during his time at Michigan Heart in Ypsilanti. Dr. Zishiri clinical interests include complex and catheter-based arrhythmia ablation, pacemaker implantation, and prevention of sudden cardiac death in patients. We are grateful to have Dr. Zishiri share his clinical expertise on such a complex subject, and thank you for being a part of the Minnesota community. Welcome.
Perfect. Thank you for having me over here, and it's not common that I get asked to speak at an aortic center, being an electrician, a heart rhythm cardiologist, but it's been quite interesting to listen to the previous speakers, all who have spoken very eloquently, and I'd like to point out, the patient survivors. I found their stories very edifying, and hopefully I'll become a better provider as I talk about this. So when I got asked to speak about, at this session a few months ago, I thought, gee, what can I say about aortic disease and arrhythmias? And over time, I decided that maybe I could share some stories and that will highlight the conduction system of the heart and how it's related to the aortic root, and show you some of the things we're passionate about in the field of electrophysiology. So I have no conflicts of interest to disclose for this talk or others. As I was coming up with the goals, I decided to review the anatomy of the cardiac conduction system and introduce some of the tools that we utilize in the EP lab, both to understand any cardiac rhythm abnormalities, to locate where they're coming from, eliminate tachyarrhythmias, as well as treat bradyarrhythmias. I will mostly do a show and tell type of presentation, and I'll show some EKGs and some images, and briefly review some of the things that we do in the EP lab, and hopefully, as I do that, I'll save a few minutes. The Q&A session, I think, is going to be at the end after all the speakers have spoken, and I hope to not bore you to death as I do that. Okay, so this picture shows the conduction system of the heart. So, do I have a pointer here? Yes. No, there's no pointer. Oh, well. I basically live and breathe, the anatomic relations of this picture as we see. So at the top of the screen, on the yellow mark, is where we typically have the compact AV node, which is the structure that connects electrically the top chambers of the heart to the bottom chambers of the heart. And it typically sits at the apex of the triangle, which is called the triangle coke, where on the picture it is written His bundle region over there, and it is bound posteriorly by this structure called the tendon of Todaro, anteriorly by the septal leaflet of the tricuspid valve, and inferiorly by the coronary sinus ostium. I always think about this picture and look back at, when I was newer in the field of electrophysiology, and a lot of electrophysiology actually happens around the structures that we are talking about here. When we typically implant pacemakers, we're crossing the tricuspid valve for a ventricular lead to go into the right bottom chamber. Some people need what's called a biventricular pacemaker, where we pace the left bottom chamber, and we typically access that through the coronary sinus and one of its branches when we're doing that endovascularly. We spend a lot of time in electrophysiology working in the left atrium for people who have different types of atrial arrhythmias, atrial fibrillation, and such. And the fossa ovalis, which is pictured up in the middle, is how we typically get what's called transeptal access to access the left atrium. When we do flutter ablations for people that have right atrial flutter, is typically by the eustachian valve going into the inferior vena cava. There are lots of patients who have arrhythmias from the crista terminalis region, which is labeled CT up there. So in this picture, many electrophysiologists breathe and live their professional lives working around the different abnormalities that can exist in this. And since this is an aortic talk, I would also highlight that just above the yellow picture over there is where the aortic root typically sits. So even as we're implanting pacemakers in the modern day, we try to do what's called conduction system pacing for patients that need pacemakers. You either are visualizing when you can visualize it, and for patients that have had aortic valve surgery or have calcification in the aortic root, you can actually visualize it under fluoroscopy or x-ray as you try to do that. And you aim for that region, and then you can look at the different electrical parameters to do that. So I'll move on and talk about AV block, which is common in patients that have aortic valve disease, either as just a progression of the aortic valve disease, because many patients have aortic root disease and they get calcification and fibrosis that extends into the aortic root and oftentimes involves the conduction system of the heart. Sometimes AV block can be caused by medications that are used to treat some of these conditions that are associated. I know colleagues from pharmacy had spoken about some of those medications. Most patients that get beta blockers are not necessarily going to get, AV block from it, but occasionally in predisposed patients, you may see some of that. In the olden days, many patients used to be on this medication called digoxin. There are many patients who require antiarrhythmic medications such as amiodarone, and when those are used over long periods of time, typically sometimes people can get AV block, and this may require permanent pacing. The commonest form of AV block, though, that we see in patients with aortic disease is just degeneration, wear and tear from aging, and calcification and sclerosis of the conduction system, which can be part of normal aging, may not necessarily be associated with aortic disease, but many patients that have aortic, specifically valve disease or aortic root disease, may have a higher tendency of getting this. There are many, many causes that are listed here, and every time that I see a patient, my job is to make sure that it's not one of these causes. Some of them can be, isolated to the electrical conduction system of the heart. Some of them can be part of a systemic condition, sarcoidosis. Some of it can be infection, right? And if someone comes in and they have an acute infection that's involving the conduction system of the heart, putting in a pacemaker without addressing the infection is not the right thing to do. So typically you want to talk about that. I know one of the patient survivors spoke about having endocarditis and such, and I'm actually going to share a case later on of someone who had endocarditis, which unfortunately also presented as an aortic root abscess and AV block. And if you don't connect the dots, you may not always know it, but our job is to do the due diligence and make sure that we look at that. So AV block on EKG, for those that have seen EKGs or had EKGs and looked at their own EKGs and such, would typically present as a slow heart rate where the top chambers, the little blips that you see in the middle, which are the sinus beats, are not communicating with the ventricles through that bridge, which is called the AV node. And sometimes people have an escape rhythm, which is slow. Sometimes it's unreliable, like this specific patient. They have a very slow escape rhythm, which is wide, which is the bigger squiggles that you see right there. And then the third escape rhythm is coming from a different source in the left bottom chamber. So if this patient shows up in the ER, if they can't get a pacemaker before the sun sets and it rises, a permanent pacemaker, then they should for sure get a temporary transvenous pacemaker, because this is an unstable escape rhythm that is going on right there. Okay? Many patients also have atrial fibrillation, and instead of being in normal sinus rhythm where the normal electrical signal of the heart is commanding the bottom chambers to beat through the AV node, when you're in AFib, the left top chamber is quivering and is in control of the beating of the top chambers of the heart. So even patients with atrial fibrillation can get AV block, and the way that it shows up on EKGs is that instead of being irregularly irregular like atrial fibrillation typically is, it shows up as a regular, sometimes slow rhythm. Sometimes it's not too slow, like this specific patient who had AV block. Many times from just looking at the EKG, looking at the history, lab work and such, we can figure out where the AV block is. But occasionally, people wear halters or these wearable things. Maybe someone has felt dizzy or lightheaded. It's not clear that this is related to a slow heart rhythm or not. And occasionally, we actually bring people to the EP lab where we study the electrical system of the heart. We typically go in through the femoral vein, which is in the groin area, and then we put in very specialized catheters that can measure the electrical signal of the heart. So in the picture here, we're measuring an electrical signal in the high right atrium, which is HRA over there, and we're measuring a signal across the natural bridge that conducts electricity from the top to the bottom chambers of the heart, what's called the Hespando region. So in this specific picture, we see that as, if you look at the first beat, for people that are used to looking at EKG, the first little squiggle is followed by a QRS complex. The next one, there's a P wave that's not followed by a QRS complex, and the level of block is in the bundle of His because the His signal is activated before there's any conduction down to the ventricle. So this, again, would be a high-risk situation. So if you saw this just on a Holter, there would be some P waves that don't conduct. You don't know if this patient needs a pacemaker or not. But with an EP study, you can determine that this is a high-risk feature, and maybe this patient may be able to benefit from a permanent pacemaker. Treatment of AV block, again, if it's something transient, or if someone is hemodynamically stable, there's many medications, atropine, there's beta agonists, norepinephrine. If someone was on digoxin and you think they have dish toxicity or calcium, non-dihydropyridine calcium channel blocker, you can give glucagon to counteract those. And if it improves and you are satisfied that you've reversed the temporary situation, then there's no specific need for a permanent pacemaker. However, for many of these patients, there's need for permanent pacing. If it's soon after open heart surgery, my surgical colleagues are going to speak here, but many patients who get valve disease also get temporary epicardial pacing wires because sometimes people get heart block, which could be, or different bradyarrhythmias that could be transient in the immediate post-surgical period. And if that persists beyond a certain amount of time, or if it's not going to be reversible, typically we would recommend a permanent pacemaker as well. I'm going to now move on to show some ECGs and review some of the EKGs that talked about this learning objective about AV block and how it relates to the conduction system of the heart. So I know several different speakers, if not almost every speaker who spoke before me today mentioned bicuspid aortic valve in some shape or form. Most of the times when that was mentioned, it was in relation to, the valve disease that occurs with that and the ascending iotopathy and the risk of dissection and such. But, because the valve is functionally abnormal and 1 to 2% of people are born with this bicuspid aortic valve, some people can get risk for getting infections associated with this. It can be from your teeth. Sometimes it can be from other transient causes of bacteremia, which is growth of bacteria in your blood. So this is a patient I saw recently. He's 36 years old. He had a murmur. He had known that he had a bicuspid aortic valve, and he was admitted with fever and dizziness. He came in through the emergency room. His labs were notable for an elevated white blood cell count. He also had a new iron deficiency anemia, which had been progressive over the preceding few months. Blood cultures were obtained, and 4 out of 4 of those blood cultures grew this organism called strep bovis. So typically, when you have strep bovis and it causes endocarditis, you have to be worried that someone may have a colonic tumor that's bacteria that exists in the colon, typically. And unfortunately for this young man, that's what he ended up being diagnosed with. Unfortunately, he had aortic valve endocarditis due to strep bovis. His EKG shows a sinus tachycardia with complete heart block and narrow escape rhythm, and he had an aortic root abscess. We have a very young man with a congenital disease. He had developed, of course, infection because his valve is predisposed to that, and unrelated to that, but which helped get this diagnosis, is the microbe that he grew, which showed that he also had a colonic tumor as well. Okay. I had another patient a few weeks ago. Many patients that have aortic valve disease nowadays get transcatheter aortic valve replacements, and the patient had AFib for a long time. They had an uneventful transcatheter aortic valve replacement a few weeks earlier, but over the last few days prior to admission, they've been having dizziness and near syncope, and this is an EKG that shows AFib with complete heart block. So when they deploy that aortic valve, it can compress on the conduction system of the heart, and some people can get heart block with it, and this patient needed a pacemaker as well. Again, in electrophysiology, many times we see people that are older just because, the conduction system and arrhythmias can be more prevalent in older folks, but we also see a fair number of young folks for supraventricular arrhythmias, Wolff-Parkinson-White, and occasionally we actually get patients like this one who had congenital complete heart block. So some patients, especially if the mom had lupus or circulating lupus antibodies, can be born with congenital complete heart block. Some of these younger children who have complete heart block may have underlying congenital heart disease. AV canal defects, patients with trisomy 21 are at very high risk of getting this congenital complete heart block. So this EKG is showing sinus rhythm with complete heart block. And after a therapeutic intervention, now you can see that the top chambers and the bottom chambers are following each other with a paced QRS that is actually very narrow, because in this patient we're able to put in the so-called conduction system pacing. And some people might look at that EKG and not be able to tell that there's a pacemaker that's working right there. Okay. We also see a lot of patients who have fast chamber or fast arrhythmias from the top chambers of the heart. And periodically after aortic valve intervention, whether it's surgical intervention or transcatheter aortic valve intervention, just because of the changes in the conduction properties of the AV node, some people can get supraventricular tachycardias. So we typically study them, just like normal electricians would do with different tools. You put these catheters, and our catheters are typically deflectable. You can bend it. They have different curves on them. They have a different number of electrodes, so you can actually measure different electrical signals from the different chambers of the heart. And typically, again, unfortunately, I don't have a pointer here, but this is fluoroscopic image in the right anterior oblique, almost like the fluoro image looking from the right of the patient, about 30 degrees or so. And the wire that's coming down with the 4 electrodes right there is in the right bottom chamber. The wire with the 10 little dots almost looking obliquely across the screen is in the coronary sinus, and that other 4-chamber 4-dot wire that's at the almost apex of that blue ellipse is recording the hispano region. So again, this is very similar, but shown in a different way to that first diagram I showed you about the triangle Coke. So once an electrophysiologist puts these catheters in these positions, you can actually study the electrical activity of the heart in a very detailed way and understand what's working well, what's not working well, what's causing short-circuiting, and you can deliver different treatments. So typically, those catheters would give you recordings that are like this. I tried, and I promise not to bore you with the details of this, but we typically measure the electrical time that it takes to get from the top to the bottom chambers of the heart, and there's normal ranges for that. We figure out after we get the catheters in place, if someone's having a fast heart rhythm, whether they've got what's called D.r Zishiri physiology. Do they have an accessory pathway, what's called Wolff-Parkinson-White? Sometimes it's manifest, meaning on 12-lead EKG you can see it. Sometimes it's concealed, meaning you can't see it on 12-lead EKG, or it doesn't conduct from top to bottom, but can conduct from bottom to top, but can still cause these arrhythmias. We pace different parts of the heart, the top chambers of the heart, the bottom chambers of the heart. We're literally doing an electrical experiment, trying to see what's working well, what's working normally, what doesn't work, what's short-circuiting, and what are the kinds of arrhythmias that people can experience. And through pacing, sometimes medications, adrenaline-type medications, many patients who have supraventricular tachycardias, sometimes it's provoked by exercise or stress or anxiety or those kinds of things. So we have medications that we can utilize in the lab to try to recreate the clinical scenario that the patient is experiencing. Once we do that, we try to understand, is there a one-to-one relationship between the top chambers and the bottom chambers? Is it what's called long RP or short RP? And that means different things to us. And how does it start? Suppose you start a fast arrhythmia. How does it terminate? And then when you get certain changes in the cycle length, what exactly is happening? And that gives you a very detailed information about what kind of arrhythmia someone may be experiencing. The aortic root, again, like I said, it's not just a bridge for how the electrical signal gets to the bottom chambers of the heart from the top chambers of the heart. But sometimes we do see patients that have these atrial tachycardias, which is a focal source of ectopic electrical activity in the top chambers of the heart, and it's actually localized to the aortic root. And the different pictures that I have there try to show it, with an angiogram. You've got an aortogram in there, you've got catheters, and the red stuff that you see there is when you're mapping on the right side, and it localizes to what's called the his bundle region, but then you know that it's localizing there because that's where you're measuring, but you actually have to measure in the structure that's behind it, which is the aortic root. And there's been numerous case reports of ablations of these aortic root tachycardias. We also spend a lot of time taking care of patients with bottom chamber arrhythmias, ventricular tachycardia, PVCs, and many PVCs. I would say in my practice, maybe 2/3 of the PVCs that I get to see, the so-called outflow tract arrhythmias, actually originate in the aortic root. And PVCs means premature ventricular contraction, and many times they're benign, sometimes they're not. They can cause heart muscle weakening. And I'm going to show and share a case of a 51-year-old female with hypertension, and she had very symptomatic PVCs. She had been tried on different types of medications, including beta blockers, a heart rhythm medication called Sotalol, and despite her age and the potential side effects with amiodarone, actually someone had tried to put on amiodarone as well. And her ejection fraction, which is a measure of the efficiency with which her heart functions, was 40%. And she had heart caths, other things, and we concluded that these PVCs, because they were occurring with such high frequency, were likely the reason why her heart muscle was weakened. She was referred to us to figure out what else we could do, and that's an EKG of her PVCs. So they are right bundle in morphology. So if you look in V1, typically we look at the axis. They're called inferior axis, meaning they've got a very high peak on the R wave in the inferior leads, 2, 3, and AVF. And you can see that they're dominant across the precordial leads when you look at V1 through V6. So this suggests that this is a left ventricular outflow tract, very basal, possibly from the left coronary cusp. So after we discussed the options with this lady, she agreed to come in for an EP study and with possible ablation. And this is in the lab, so it looks a little bit different than the EKG. But you can see that we mapped, and in the left coronary cusp, we found this area which was 13 milliseconds. So 13 milliseconds before the onset of that PVC, and looks like this is where it was coming from. Because it's in the aortic root, we have to be certain that it's a good and safe place to ablate. And on this picture, using intracardiac echo, which is a real live image of someone's heart. As we do that, we can see the aortic cusp. So this patient had a tri-leaflet aortic valve, which was otherwise normal. At the bottom of the screen, at 6 o'clock on the screen, that's the left coronary cusp, and that's where we were mapping this PVC to. At about 3 o'clock on the screen, the other cusp that's up there is the non-coronary cusp, and at about 1 o'clock on the screen, 1 to 3 o'clock on the screen, is the right coronary cusp. In fact, in real life, you can actually see the coronary sinus ostia, which you have to worry about if you're on the coronary cusp, because I don't want to deliver heat energy and cause a heart attack in someone. With the ultrasound software that we use when we map, you can actually define those, and you can know within a millimeter of distance of where exactly your catheter is, and you can be sure that this is a safe place to ablate. And on the next image, in what's called the long axis view, you can actually see where deep within the aortic cusp the coronary arteries would come from, higher up and not as deep in the coronary cusp. And this image I also like because it also shows the tricuspid, cavo-tricuspid isthmus, where we sometimes do ablation for flutter and such. And once we were sure that this is where this abnormal heartbeat was coming from, and this is a safe place to ablate, it's deep within the coronary cusp, it's at least 10 or so millimeters away from the coronary sinus ostia, we come on ablation. So at the top of the screen, you see where it says ablation on, maybe halfway through the screen right there. And then you see how there's those little blips. And soon after we come on, there's one blip that comes, and then subsequently the heart rhythm is normal because we found exactly where this extra heartbeat was coming from. So after we mapped in the left coronary cusp, we gave 20 watts of radiofrequency ablation, and she had one more PVC, and she has never had any more. I followed this lady for a few years now. Her ejection fraction is now normal. She doesn't take medications, and she's literally discharged from my practice. So I hope I didn't, go way out on a limb to excite you about, the electrical system of the heart, but it's for sure related to the aortic root, and the aortic root and its anatomic relations are critical for normal cardiac anatomy and cardiac electrophysiological disease in the aortic root, the adjacent structures, which we spoke about, and their treatments, these valve replacements or transcatheter valve procedures sometimes result in heart rhythm conditions. Thank you for your time. I will look forward to taking some questions at the end. Thanks.